So these are scenes of which all of us are only too familiar in slum areas where there is very, very poor sanitation, or in urban settings where people are living right next to sewage, washing their clothes, washing their foods, and so on. And we say, well, those are poor people. But those poor people, we are all, as I will show you, extremely interconnected. And this notion that those people live there and we live here in this very nice area doesn't really hold when we start to look at it. Now, let's look at the new and re-emerging diseases. We looked at those conditions which have been with us and many of which have disappeared, but now we are experiencing new and re-emerging. And I put an asterisk next to all of those conditions that are zoonoses, which I will cover in a minute. So HIV/AIDS is a zoonosis. SARS and MERS, and the present one, SARS-CoV-2, which is coronavirus, which is COVID-19, these are all zoonoses, as is H5N1, the avian flu I mentioned, and H1N1, swine flu, which was with us, and Nipah and Ebola. These are all zoonoses. That is, they originate in animals and jump to humans. We are seeing an increase in dengue and yellow fever in some parts of the world, hepatitis C, and the last, antibiotic and drug-resistant organisms, are increasing as we abuse the use of antibiotics. Now, what is a zoonosis? It's an infection or infectious disease that's transmissible under natural conditions from vertebrate animals to humans. It could be enzootic, which is endemic, which is there all the time, or epizootic, which is epidemic. So let me look here are new and emerging diseases, and you'll notice on the right there that the zoonotic diseases, a lot of these are viruses, and most of the new diseases will come from zoonoses. So let me look at that even closer. Why should we care about them? Well, if a virus develops competency for efficient person-to-person transmission, you'll get a new global pandemic. That's exactly what has happened with COVID-19. This was a virus probably picked up from a wild animal, maybe because there were certain areas where people consumed certain wild animals. We're not absolutely certain about this. And it has led to a global pandemic because none of us have any immunity to this. Now, there have been many others in the past. Measles, which we have now really controlled, really began about 1,100 years ago from a spillover from a disease in cattle called rinderpest. HIV probably came from apes, from chimpanzees. Maybe somebody cut themselves while skinning a chimpanzee. The blood got into the chimpanzee blood, got into a human. It adapted itself to the human, and over many years, the number of people with this condition increased until suddenly it broke free. All influenza comes from wild ducks, whether it's H1N1 or H5N1, they originate in wild ducks. The ducks don't get sick, but we do. And then lastly, Ebola, Nipah, SARS, MERS, COVID-19, and so on, all seem to originate from bats. Bats, which are, and that's somewhat related to our encroachment on their natural habitat, and also the consumption of animal products that themselves have been infected by bats. So it's likely that SARS and SARS-CoV-2 or SARS-CoV-2 came from bats through animals. In other words, the bat infected the animal through our consumption of it or our killing of it, then passed the infection on to us. But all of these probably originated with bats, which are very, very critical to the ecosystem. They are major consumers of many of the insects that also infect us. So here's SARS, which was not that many years ago, and the present COVID-19 is a relative of SARS, and this is just a picture from a little ballet class in China at the time of SARS. But the critical issue here, and the one that we forgot very quickly, was the very, very important use of facial covering. Whether it's this kind of mask, whatever you have, facial covering is absolutely critical because the virus enters through the respiratory tract. So if you cover the nose and the mouth, and sometimes the eyes, although it's less critical, you will drastically reduce the level of transmission and also reduce the severity of illness. Why we forgot that, I'm not so sure, but this is probably one of the most effective public health measures that we can use. Far more effective, frankly, than strategies such as lockdown, which we'll talk about. This is the Ebola virus that broke out in West Africa in 2014, and we had another recurrence in the Democratic Republic of the Congo. But this was first identified back in about 1976 in hazmat suits, going out to look for people who are infected. Remember, this is an infection where the mortality can be 40–50%. The present COVID-19, the mortality from an infection is much less, well under 1%. That's the infection, not the case fatality, not somebody who has a case and then dies, but somebody who has an infection, and that infection is probably, the mortality may well be under 0.2%. It's very low. I show this person being buried because it was our inattention to how people dealt with dead relatives and family that also contributed to the spread. The public health community, thinking that it was doing the right thing, would take dead bodies and throw them in a pit and bury them. And many of the families said, that's very disrespectful of our dead father, mother, child. And so we're not even going to tell you when we have somebody who dies. And so the disease actually continued to spread because of our inattention to feelings of individuals. So even today, people won't come to the hospital because they feel they'll be ill-treated or kept from their relative because of a public health intervention. So I just want to throw something in here on the importance of anthropology in understanding how people deal with illness and how they deal with death. Because if we don't understand that, we can contribute to the spread of disease. Lastly, this is the giant fruit bat. Many of you have seen these hanging from trees. And the bat, in this case, caused something called Nipah, which you saw, there was a small outbreak in Kerala, and it is seen along the eastern border of Bengal. There may even be cases in Orissa and also the western border of Bangladesh. In this case, it was related to pigs this was obviously in Malaysia, in the Chinese area of Malaysia, where pork is widely consumed. But the pigs ate fruit from trees where bats had defecated on the fruit. So the pig caught the virus from the fruit contaminated by the bat, and people got the infection from the pig who passed it on to them. A very interesting story. Now, and I will spend the rest of my time here talking about COVID-19. Many of you are very familiar with this. This is a zoonosis, originated in China, but then spread quite widely. And here are strategies that have been used to control this condition. Increasing physical distancing, which is achieved through behavior change, local laws, and lockdowns. And we'll look at that in a moment. Using facial covering or masks, which has not been until recently approached as vigorously as it could be. Hand washing. Hand washing is fine if you have water and soap around, but as we know, in many of the slum areas, that's not available. Coughing etiquette, coughing into into the crux of your arm, avoiding crowds, both inside and outside, but particularly inside. And then we have testing and tracing and treatment, and using technologies and drugs to reduce mortality. But I want to focus primarily on the prevention of this and look at the situation of lockdowns. Lockdowns being confining people to their home and closing down the system. Now, it may have some value in some of the European countries, in the United States, although we're doing a very, very poor job of this. But in low and middle income countries, it has a different meaning, especially where up to 90% of individuals are in the informal sector. That is, no work, no income, no food, unless government can deliver food, and that's not always guaranteed. School closings and limited distance learning. Not everybody has a computer. All of us are watching this on our computers, but we know that there are many, many people who don't have access to this. Crowded housing, which is then made worse by forcing families to live in a place where we may just use that one room as a bedroom, but in fact, there may be a family of 6 living in such a space. By limiting public transport, especially trains and buses and cars, we have also decreased access to health care. Immunizations in some areas are down 70%. TB care is down. Pre- and postnatal care is down. And then people have developed a fear. That the fear virus has been far more infectious than the actual virus itself. And people fear to go to health services even when they require them. The decrease in public transport has limited the movement of food and essential goods. And then, going back to those slides from the plague, there's been excessive stigmatization of groups and persons, completely inappropriate, and an increase in authoritarianism and human rights abuses. Now, I'm not simply speaking of South Asia, I'm speaking of globally. A lot of these issues play out. What does that imply then? Well, I co-authored a paper with Vikram Patel, which about 3 months ago now, almost 3 months ago, that looked at various principles that we need to take into account when we respond to a pandemic. Because the response can be much worse than the pandemic itself. And we argue that strategies such as lockdowns have a much greater impact, a negative impact on health than the condition itself. Why is that? Well, context is critical. That is the demographic profile of a population. How many young, how many old, who are the elderly, where do they live? All of these are rather critical. India has a much, much higher proportion of young people than in Italy, which has maybe 20-25% are over the age of 60. In India, a much higher percentage is in the young age group, and that age group has almost no mortality and morbidity. The other issue is social justice and equity. These are key. The informal sector has clearly been undervalued and unprotected. Lockdowns did not protect the informal sector. They did not protect the most vulnerable. They protected those people who could be protected because of their own situation, who are participating in this webinar. We have homes. We can have food delivered to us. We have computers. We have access that the vast majority does not have. So that lockdowns have a far greater impact on the overall mortality and morbidity. And the tragedy is, of course, that they did not reduce the spread of disease. They only delayed it by a few weeks at most, and so our position was that the critical thing is that you must develop an intervention that is consistent with your situation.